Hello, everyone out at watching ISICEM this year. This is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery at the Duke University School of Medicine. And I'm thrilled to be here today to talk to you about Propofol, the panacea, the poison, propaganda, and perhaps Paracelsus. And is it a dangerous drug in the ICU that perhaps causes ICU-acquired weakness and has other significant risks to our patients? And we should be thinking hard about using an alternative instead of Propofol, especially in COVID-19. So I don't have any disclosures for this lecture. I don't work with or for any other sedation drugs. I just have had an interest in Propofol from a metabolic point of view and its effects, its poisonous effects on the mitochondria. But if you were the average person who looked up Propofol, you would get a lot of Google results. Lots of people talk about Propofol a lot. Unfortunately, the majority of them relate to how it contributed to the death of Michael Jackson, showing that in the wrong hands, Propofol is without a doubt a risky drug, and lots of unusual uses of Propofol are occurring in the US and around the world. They're using it in sort of shady rehab centers to try to withdraw people from drugs, and lots of other strange uses of Propofol, and lots of overdoses and drug abuse of Propofol occurs in the world. But again, like any drug, and Paracelsus taught us this, poison is everything and nothing's without poison. It only depends on the dose. So whether it's a poison or not a poison, depends on the dose like any drug. But we all think of Propofol as sort of this wonder drug. It's used for everything and everywhere, like a panacea. And in the operating room, I'm an anesthesiologist as well, it is a panacea. It's an induction agent of choice for the majority of all anesthetics performed in much of the world. It has lots of great characteristics for single use or short-term use in the operating room. So it sounds like the perfect sedative. And in the operating room, it is, except it's not perhaps in every patient. And the patient perhaps it's not ideal for is the ICU patient. And why do we say that? Why would I say something like that? Many of you probably use Propofol. If I asked how many of you are using Propofol as a major sedative in the ICU, most of you would probably raise your hands. But I want you to think about that. And here's what led me to begin to think about it. This is a patient I took care of quite a number of years ago. He was a 25-year-old who was in status epilepticus. He was persistently seizing, and he'd been on 3 different anti-seizure drugs without success. So he was intubated and placed on Propofol. The Propofol was increased in dose to control his seizures, which it did successfully. On his second day, in his urine, CK and myoglobin and creatinine began to be elevated. We attributed this to his recent seizure and perhaps muscle breakdown from the status epilepticus he'd been in. He didn't have an acidosis, and we were able to hydrate him and begin to improve this. On the 3rd day, the EEG still had some seizure activity, so the Propofol was increased and burst suppression was achieved. On day 5, we were able to turn his Propofol down, but the patient became more and more tachycardic that day. And a few hours later, we noticed his heart rate began to drop and his blood pressure began to fall. We thought maybe he's getting an infection, maybe this is sepsis. We weren't sure. Then he began to get really severe bradycardia with right bundle branch block on the EKG, which was new. And his lactate began to climb suddenly. And again, we didn't know what was happening. We got very concerned, but we thought maybe it's the Propofol. We'd heard that Propofol might cause this, so we stopped it. Unfortunately, suddenly, this patient developed a Y-complex tachycardia and became exceedingly hypotensive. This degenerated into ventricular fibrillation, ultimately asystole, and CPR was started. 49 minutes later, unfortunately, after CPR, Elijah, our 25-year-old patient, was declared dead. Ultimately, his cause of death was ruled to be propofol infusion syndrome, or PRIS. So who does this happen in, and who is this a risk for? And what else does propofol do that we should be concerned about? Well, the data will show us, and I'll tell you more, that septic shock, cardiogenic shock, any pressure requirement, acidosis, renal failure, being a male, all of these put you at high risk or potential risk of propofol-related infusion syndrome. That's more than 80% of the ICU patients I care for. Why is this? Well, propofol has a range of adverse effects, that some of which you'll be aware of and some of which perhaps you're not. We know it's one of the most potent vasodilating anesthetics we give in the operating room, and anesthesiologists will tell you that. It also is the most potent negative inotrope we give and can cause heart failure. It also was mixed in a toxic lipid. It's mixed in an all omega-6 fatty acid lipid that has significant immune and liver negative effects. And it gives a lot of extra calories that often aren't accounted for that can lead to overfeeding. So, and then finally, it can lead to the dread propofol-related infusion syndrome, PRIS. What is this and how did it come about? Well, the first cases were described in 1992 in 5 children in the pediatric ICU. All developed, like the patient we talked about, Elijah, metabolic acidosis, bradycardia, myocardial failure, and they all died. And so this was a great concern. This was quite a while ago, and it really led to a lot of trouble. 70 additional cases were described in adults and children, seemed to be associated with higher doses, but lower doses also led to this fatal infusion syndrome, and there was a significantly high 80% mortality. So again, AstraZeneca said over and over, propofol is currently not approved for sedation in pediatric ICU patients, and a letter was issued in 2001 saying it should not be used for ICU sedation in pediatric ICU patients for this purpose. And this was because a clinical trial was stopped that was actually studying a preservative in propofol early because it led to 2 to 3 times the mortality in children who got it in 327 pediatric patients. And so they were studying a preservative, but propofol itself led to many deaths. And so since 1992, the cases of PRIS are up tenfold over the years, and often in patients with status where higher doses are used. But the actual incidence is unknown because some of the symptoms that propofol causes obviously can be caused by critical illness. And so the presentation is all these things like we described. You can get lipemic plasma, metabolic acidosis, often right bundle branch, rhabdo, hyperkalemia, all these things can be present. How does this happen? What's happening to these patients mechanistically? Well, propofol is a mitochondrial poison. It inhibits key enzymes of the electron transport chain, depletes ATP in the heart and in the muscle, inhibits sodium channels, can cause significant muscle necrosis on muscle biopsy, and I'll show you some pictures in a moment. So again, muscle biopsies and fat metabolism analyses in these patients looks like patients who have mitochondrial cytopathies and acquired carnitine metabolism deficiencies. These patients can't metabolize fatty acid oxidation. They can't use that, and that's vital to muscle. And so again, propofol is a poison or an inhibitor to a number of transport options, the carnitine transferase and the electron transport chain. And so this is a mitochondrial poison. And so can we predict who's at risk from getting this? Again, people with more muscle mass, it would make sense, like males, might be at risk. But a group in the MedWatch database looked at this and looked for risk factors. And what they came up with was 1,100 cases of suspected propofol infusion syndrome, very high mortality. And the things that went along with it were, again, rhabdo, renal failure, acidosis, catecholamine use, being a man or being under 18. Again, more muscle mass, more disease process, more risk of muscle injury. Again, this is 80% of my ICU patients, and many of them have these symptoms. So how do I monitor for it? And this is very challenging, and that's why this drug has a lot of inherent risk. It's hard to monitor for. But if propofol is so much better than other sedatives, maybe we should consider giving it. So is propofol really the panacea in the ICU that is in the OR? Well, even the TV doctors in the US know it's not. There's a lot of trials that show this. This is an important trial, the ANIS trial, that showed that propofol worsened delirium scores versus dexmedetomidine. Again, dexmedetomidine really is a much better drug, and this was one of those times where delirium, again, is repeatedly shown to be worse with propofol. The difference in the change was quite significant and favored dexmedetomidine or Precedex for the care of these patients. Again, I don't work for these companies, but this is just the data that's been published in our large journals. This is, of course, 2 other key studies that looked at dex versus propofol and dex versus midazolam. These are published in JAMA. Dexmedetomidine improved outcomes versus propofol and Versed. Again, dexmedetomidine is much better than these 2 drugs in clinically meaningful sedation outcomes. Reduces the duration of mechanical ventilation versus midaz. This is Precedex. And it reduces the time to extubation versus midazolam and propofol. So it's better at getting people extubated early, and it reduces delirium versus propofol. Again, this is a JAMA study. Improves the ability of the patients to communicate, reduces neurocognitive adverse events versus propofol, and reduced ICU polyneuropathy. This is our first signal that it could affect ICU-acquired weakness. So dexmedetomidine led to less ICU-acquired weakness versus propofol, and that was significant. So again, clinically relevant benefits from dexmedetomidine versus propofol and other drugs. So there's been many other trials since then. This is in cardiac surgery, reduces delirium, and shortens the duration of post-op delirium in elderly cardiac surgery patients. Number needed to treat of 7. So again, you're going to improve your outcomes if you use Precedex versus propofol. This is 10 randomized controlled trials that were meta-analyzed. Dex was, again, dexmedetomidine superior to propofol. Decreased length of stay and decreased risk of delirium. So again, this showed that reduced mechanical ventilation times, of dexmedetomidine versus propofol that was quite significant in this case, particularly against that drug. And so again, you're going to get better extubation times and you get less delirium. Again, the same versus propofol. So again, then this paper came out recently that showed in a study from the Canadians that ICU-acquired weakness was significantly higher in patients who received propofol, almost twice as high, 65% versus 33%. And they hypothesized this goes back to the mitochondrial poison effects on the muscle of this drug. So again, propofol exposure increased the risk of ICU-acquired weakness in sepsis patients, and also interaction with the sodium channel inactivation is hypothesized. There's lots of negative effects of propofol on muscle. The odds ratio of developing ICU-acquired weakness was 3.4 times higher in propofol than in other drugs. So again, there's a number of postulated reasons. This was a recent review of ICU-acquired weakness. Propofol and benzodiazepines decrease muscle excitability and worsen the effects of bed rest, whereas other drugs like ketamine has a positive effect on maintaining muscle trophism and muscle size. So there's better choices probably. This was an interesting paper that was just published a few months ago. It was a small study of animals sedated with propofol versus thiopentol. It was pigs. All the propofol animals had significant spontaneous ENG activity. We've seen in some COVID patients, there's significant muscle fasciculations going on in 40% of COVID patients. We think it may be related to propofol and lead to hypermetabolism. The mean CK only went up in propofol-treated animals, not in thiopentol-treated animals, so it's clearly injuring and killing the muscle. These are muscle biopsies showing significant intracellular localization of extracellular proteins. So plasma proteins are getting into necrotic muscle cells in the propofol animals, especially at day 5. And you can see the purple dots are tunnel staining and apoptotic cells from this. So although not conclusive, this implies that the propofol infusions may not be appropriate sedation for adult COVID patients undergoing mechanical ventilation, and that we probably need to find other drugs and we need more research. This is a problem. So our guidelines also show that in COVID-19, severe hypertriglyceridemia is occurring even in low propofol doses. Many of you have probably seen this. I've seen it many times. There's a significant defect in the metabolism of triglycerides in these patients. But then we'd say, well, maybe dexmedetomidine costs too much, and so we can't afford it, but that's not true. Study after study is showing that patients on dexmedetomidine have a significant financial savings versus propofol, as much as $2,000 per patient. And the same was found, almost 2,600 euros per patient when dex is used versus propofol or other drugs. So do I need to tell you any more? If I have to use propofol as I finish my lecture, can I do it more safely? First, keep the dose below 50. Again, the old data would say keeping it below 50 or using it less than 48 hours. Avoid it in males, perhaps, and patients that have seizures or status epilepticus is one way to go. Definitely stop it if you see these features. But now there's data that shows that even at low dose, we might still be getting PRIS. This is a recent publication in Critical Care that showed that it is independent, perhaps, of the dose of propofol, and idiosyncratic signs, acute kidney injury and hepatomegaly, are being seen with propofol at lower doses. Cardiac failure and metabolic acidosis appear to be related to dose, but arrhythmias and rhabdomyolysis can occur irrespective of dose. Even patients who get sedations in the OR get myalgias, it's reported, from propofol and muscle injury. So again, this appears to be due to the inhibition of the respiratory chain for dose-dependent effects, while it's the late time-dependent signs are by inhibition of fatty acid oxidation. So this can happen in anybody, and so you need to watch for fever, hepatomegaly, and heart failure, and it's hard to see these often in our patients. So ideally, as I finish, minimize propofol use dex, and dex will improve your outcomes versus propofol and lower your cost. For dex to work, you have to give enough opiate. But on the flip side, propofol masks untreated pain. We have to probably give too little pain medication to those patients. So although it's a panacea in the OR, it's a poison in the ICU, and we have better choices. And in closing, Michael Jackson said there's something that can take you to the valley of death. He was talking to Deepak Chopra, and he didn't have any idea that it was propofol that he was talking about. And I would like for us to find ways to keep our patients from perhaps being injured by propofol as well and use other drugs. Be happy to answer your questions. You can reach out to me on Instagram and Twitter. And thank you for your attention.